appear here. Is it mandatory to know all that? And especially, we are going in the next few minutes to talk about the medical treatment. And the answer is yes, at least to be oriented, at least to know what they are talking about. Because even as a surgeon, you are one or a member of the multidisciplinary team regarding the inflammatory bowel patient. You have to participate in the decision. The gastroenterologist, the histopathologist, the surgeon, the radiologist, all will communicate even at the level of the diagnosis, not only at the level of the surgical treatment. So we have to be oriented. Okay, now we move to the medical treatment of inflammatory bowel disease, and we first want to talk about the medical treatment of ulcerative colitis. Okay, with regarding of the medical treatment of ulcerative colitis, so it is a combined between medical and surgical treatment, and we know that surgery is curative for ulcerative colitis, but it's not an easy decision, especially in the recent years with the development of many medical agents, including the biological agents. So the decision is not that easy. And the goal of therapy, we have to remember that we have two main goals. First is to induce the remission, and the second is to maintain the remission. And this is actually guided by many criteria, and usually the treatment is extremely individualized. Every patient have to be studied as a one entity separate from another, no one single protocol for all patients. For example, criteria that play a role in the determining what medication should be given. For here, the age of the patient, the anatomical extent of the inflammation, the symptoms, severity, the treatment response, the risk factor, the risk of the and adverse effect of the medication, all these play role. Our goal of the therapy is to resolve the inflammation, lessen the symptoms, improve the quality of life, minimize the risk of long and short-term complication. Operative intervention usually in ulcerative colitis to control the complication, or in patients who are refractory to medical treatment. Here is a triangle or pyramid. You can see it's like a ladder. We start from the simplest agent till we reach the surgery. It's important to memorize that. For example, in ulcerative colitis, we started with sulfasalazine and 5-aminosalicylic acids compound. Actually, there is a medication before that called the hemotherapies. We will mention them. And then we move to corticosteroid, and we have to remember that corticosteroid, there is traditional corticosteroid and the budesonide, which is an agent for a corticosteroid special for inflammatory bowel disease. And then we move a little bit step for immunomodulators such as azathioprine, 6-mercaptopurine, and methotrexate. We move up step for biological agent, and we will mention them. Biological agent is a step before we go to the surgery. Here they mention that nutritional support we can give. Okay. Actually, you can say step up approach and step down approach. We go up and then we hop to go from, for example, from steroid, we go back to sulfasalazine. Okay, regarding if we want to talk about each one briefly, actually in this part they just review what we just said, the agent that can be used, that the patient should be counseled well about the medication and its side effect, about that uh, that we have to follow up the patient response regarding each one, how we can move, why we should move from one drug step up because of the side effect, the unresponsiveness. Some patients prefer surgical treatment. Some studies have done about the preference of sorry, the preference of or how decision can be done by the gastroenterologist or the surgeon. The surgeon always push toward the surgery. The gastroenterologist would keep the patient within the medical treatment. Some patients prefer to be on medical treatment before proceeding. It's general study and multiple many percentage. One of the conferences I have participated in inflammatory bowel disease, the conclusion was it's not a conclusion, but one of the gastroenterologists, expertise gastroenterologist, said that our goal is to keep the patient far away from steroid and far away from the surgeon knife. Okay. First, I want just to review rapidly every single agent that we can use it in the treatment, in the medical treatment of ulcerative colitis, and the first agent, or at the lowest step in our ladder or in the base of our pyramid, is the what we call it hemopathic agent. Hemopathic agent is an old fashioned of the treatment of the diseases called treat like with like. Or example of that is curcumin, which is really interesting. The study found that curcumin really decreases the risk, or can a response can be seen, especially in ulcerative colitis and especially in mild diseases. And it could be used as an adjunct in mild diseases with mesalamine. Okay, regarding the probiotic, and the probiotics is a beneficial microorganism that can potentially impact in the gut microbiota. Again, this medication, I want to highlight that this medication, even the curcumin or the hemopathic agent, probiotics, have, even by studies, proven that they can control the disease in its mild form in ulcerative colitis, but we will see later that they are of no benefit in Crohn's disease. So there is a rule for curcumin treatment, for probiotics treatment, which is the potentially beneficial microbiota composition, especially this formula which contain bifidobacteria. Here is an example. I don't know, this is a commercial 5-strain bifidobacteria. This is an example. So there is a rule of this medication, but in the first step of our ladder, we move up a little bit to 5-amino salicylic compound. And 5-alpha salicylic compound, if you remember the diaphragm here, it's in the first step of our treatment. Actually, they are used to control mild diseases Um, uh, the main two drugs are the sulfasalazine and mesalamine. Okay, how they work? They work by activating a class of nuclear receptors involved in the apoptosis of cell and proliferation and inflammation and mitotic function. What we can add about sulfasalazine here is the sulfasalazine. This is the main drug of the 5-aminosulfasalicylic acid. It can be, of course, tablet. It can be rectally as suppositories or enemas. Actually, the sulfasalazine differ from mesalamine in its, here is it, sulfapyridine moiety components of it. Here the sulfapyridine carries a multiple side effects. So the sulfasalazine carries side effect more than mesalamine. Okay, here is the mesalamine. Also, you can see in tablet, but I have to mention that in a form of if the disease is limited, for example, proctitis or left-sided, we can use transanal topical therapy in a form of suppositories or enema of sulfasalazine and mesalamine. Also, there is a side effect, especially in the sulfasalazine, more in the sulfasalazine due to the sulfapyridine components. Of these are most common the gastrointestinal upset and the headache. Okay, rare bone marrow suppression, fever, hemolytic anemia, hepatitis, hypersensitivity reaction, pancreatitis, pneumonitis, and rush. We have to give folic acid as folic acid is depressed and when we took this medication 1 milligram per day because they deplete the folic acid store. Also, we have to discontinue the sulfasalazine if idiosyncratic drug reaction happens, such as agranulocytosis, pancreatitis, pneumonitis, skin rash. We have to discontinue. We say that mesalamine is more safe. Okay, regarding the corticosteroid, if we move a little bit up again, we move to corticosteroid, prednisolone, and budesonide. Okay, corticosteroids. And if you remember, we said we have the traditional corticosteroid or prednisolone, and we have the budesonide, which is come in three forms, three types, three different capsules. One are specialized to be released in the terminal ileum, other are specialized or designed to be released in the right colon, while the budesonide MMX are designed to be released all over the colon. Okay, of course, glucocorticosteroids have many side effects, but budesonide have a little side effects. They are related to the dose and the duration of the treatment. How in general glucocorticosteroid works? It's by they modulate the immune system, inhibit expression of adhesion molecule, and decrease trafficking of the inflammatory cell to the intestine. Okay, the problem we said with the side effect, of course, one of the problem that can face us is the resistance and dependency of them of the side effects. We know the side effects of corticosteroid: abdominal stray, acne, cataracts, fluid retention, glaucoma, hyperglycemia, hypertension, insomnia, mood disturbances, moon phases, and weight gain, musculoskeletal problem, myopathy, osteoporosis. Also, adrenal suppression should be remembered. Of course, rectal and oral budesonide are of very little risk, so it's suggested. Budesonide goes liver pass affect very first pass liver metabolism very fast, so it's a very little risk to use. It's usually used for moderate to severe disease. We will see later. Immunomodulator. And immunomodulator is a group that have many agents, of them the thiopurine and thiopurine, example of them as the azathioprine, 6-mercaptopurine, and also methotrexate is an immunomodulator. Calcinurium inhibitors such as cyclosporine and tacrolimus is an immunomodulator. Janus kinase inhibitor, tafacinib, we will see it later, is an immunomodulator. So these are four subgroups: the thiopurine, the methotrexate, the calcinurium inhibitor, and the Janus kinase inhibitor. They are usually not used as a monotherapy. They are usually used for tapering patients who are steroid dependent, and we want to give him an alternative option. If we are talking about thiopurine, we have two main drugs. These are the azathioprine, which is the main precursor, and the 6-mercaptopurine. And I want you to remember this enzyme, which is needed to TPMT, needed to complete the cycle of which is called thiopurine. Here is thiopurine methyltransferase. Thiopurine methyltransferase. Why I want you to remember it? Because in some patients it could be deficient, so it's contraindicated to be given. And if you remember, that was one of the indication to do genetic testing in these patients before giving the treatment. You can here see the final thioguanine, the final results of what can it give us. Here is that the 6-thioguanine and 6-methylmercaptopurine. These are final products that can be given. What we can also, this is an example of azathioprine, and this is an example of 6-mercaptopurine. I don't know why I added this picture, maybe just to increase our imagination. Important to monitor the drug and dose level, and they advise routine monitoring for complete blood count. Another thing, the blood count should be monitored every 1 to 2 week interval, because we have a problem as a side effect of leukopenia and bone marrow suppression. The most common side effect of azathioprine is nausea, but also liver function abnormality, leukopenia, and pancreatitis is well known. Regarding the pancreatitis, it appeared 8 weeks after the starting of the treatment, and this is an indication to discontinue the treatment, as it will recur if we said monitoring of blood count is recommended every 1 to 2 weeks, and then every 3 months, or according to the dosing. We said that there is evidence that it may cause acute or delayed bone marrow suppression. Okay, some studies shows that there is a risk of between or slight increase of risk of lymphoma and the thiopurine medication. Okay, some studies also found that there is 10 more time increase in the risk of serious infection. What does serious infection? They didn't mention, but this is regarding thiopurine. Please remember 6-mercaptopurine and azathioprine and the enzyme that need to be monitored before the treatment. Methotrexate. And methotrexate is a agent of immunomodulator. If you remember, we said thiopurine, then methotrexate, and methotrexate is a folic acid analogs. Okay, which a folic acid analog. Okay, folic acid analog which inhibits the activity against many enzymes in the metabolic pathway of the folic acid. It actually inhibits the production of thymidylate, purine, and methionine, and lead to accumulation of finally of the adenosine, which is a potent anti-inflammatory purine nucleoside. Okay, what we can say about methotrexate also, these action they usually they reflected on the decreased formation of the antibody, inhibit cellular proliferation, and reduce the production of inflammatory mediator. The methotrexate is taken weekly by oral injection or subcutaneous or intramuscular or subcutaneous injection. The dose doesn't matter. We should give folic acid 1 milligram daily concomitantly with the treatment of methotrexate. The children have came from school and they are noisy a little bit. Okay, we said that folic acid should be taken. Of the frequent side effect is the gastrointestinal upset and stomatitis. Leukopenia is also occur but less frequent than thiopurine therapy. A rare complication are the hepatic fibrosis and sensitivity pneumonitis. This is how methotrexate sub-Q looks like. This is how methotrexate tablet looks like. And we now move to the third agent in the immunomodulator. Thiopurine, methotrexate, calcineurin inhibitor. And calcineurin inhibitor, we have two agents. The first one is cyclosporine and the tacrolimus. I hope the pronouncement is well. Eventually, they reduce the T cell proliferation. Here you can see the T cell, and here you can see the calcineurin inhibitors. For example, tacrolimus, how it inhibit the calcineurin, and eventually they reduce interleukin 2, production of interleukin 2, and ultimately they reduce the T cell T lymphocyte proliferation. It can be given as oral ingestion or as intramuscular. The intramuscular is faster to achieve, more quick to achieve the target. And the main side effect is gastrointestinal symptoms, gastrointestinal interiness. Other complications include gum hyperplasia, hirsutism, hypertension, and renal dysfunction or tremor. Okay, the discontinuation of the drug is usually related to the side effect, the GI side effect, intolerance. The last one in the immunomodulator is Janus kinase enzyme inhibitor, and this is a one agent tofacitinib. Here is it. What's unique about this medication? Okay, tofacitinib. Actually, the studies is still. This is a new agent. They found that high dose 10 milligram twice daily is associated with multiple side effects, including clotting. So the recommended dose is lower dose, 5 milligram weekly. And they are used for moderate to severe disease or patient who failed the standard treatment of mesalamine and glucocorticoid. We are in a higher level of treatment. We step up in our pyramid or our ladder. A risk for hyperlipidemia and infection present. So this is how tafasitinib look like. Okay, biological agent and biosimilars and anti-tumor necrosing factor is the first subgroup of the biological agent, and these include infliximab, golimumab, vidilozumab. I hope the pronouncement is well. I don't frequently use them. Ustiracunemab. Actually, these medications are used for moderate to severe disease or those who are refractory to steroid treatment. Here it is. And doesn't respond to standard treatment. Okay. We don't to talk in depth in the dose, as this is the interest, I think, of the medical doctor or the gastroenterologist. Okay, we said adalimumab, golimumab. The dosing is different. For example, if we are talking about infliximab, it is 5 milligram for every kilogram, whereas adalimumab 40 milligram, and one of them is 10 milligram, I think. I don't know. Golimumab is 10 milligram. What I can say about what can benefit us as a general surgeon, the administration also, how we started infliximab, patient are generally administered. It's not, I don't think it's in our interest. We should know that one of the side effects of the anti-tumor necrosing factor agent is the increased risk of infections such as TB and autoimmune reaction, heart failure, liver failure, dysfunction, lymphoma, and multiple sclerosis. Ongoing infection is an absolute contraindication to treat patient with this biological agent. Prior to starting the treatment, we should screen for occult infection secondary to hepatitis B and tuberculosis. Actually, what's written here about dosing, how we initiate, what's the interval, we don't just. The second agent in the biological treatment is vidalozumab, similar to, it's just mechanism different. It's integrin receptor antagonist, which is a biological agent called vidalozumab. Also, a second subgroup of the biological agent. Here it is, vidolizumab. I think it's the interest of gastroenterologists to tell us when to use it, when to discontinue. But the indication for the, as we said, for the biological agent, anti-tumor necrosing factor, integrin receptor antagonist, which is vidalozumab, and ustiracunemab, interleukin 12 and interleukin, the third subgroup. These are for moderate to severe ulcerative colitis, or who doesn't respond to traditional treatment with corticosteroid. Here is also the ustiracunemab, which is interleukin 12 and interleukin 23 inhibitor. Here is it, multiple forms. It's enough to remember. So again, to summarize what we said that the biological treatment, these are the three similar name but different group according to its Mechanism of action, anti-tumor necrosis factor. An example of them is the infliximab, adalimumab, and golimumab, and the integrin receptor antagonist, vedolizumab, please apologize me for the pronunciation, and interleukin 12 and interleukin 23 inhibitor. These are osteoconimab. These are the biological treatment. Let's move to the treatment and when to start the treatment. Here we are going briefly to talk about the disease severity. We talked about the disease severity, but because it will guide us about the treatment, when to give this agent and when to give that agent. Okay, as we will see later, the treatment is guided by the severity, by the disease severity. So this is why we are talking about the disease severity. Yes, I know we have mentioned it before, but again, we have the concept in ulcerative colitis: mild, moderate, severe, and also mild to moderate and moderate to severe. This is, if you remember, I told you that we are going to review them according to the true love and wit score. If you see, here is mild, moderate ulcerative colitis, and severe ulcerative colitis. This is according to the frequency of defecation, blood stool, fever, tachycardia, anemia, the ESR, and we classify it to mild, moderate, and severe. If we are talking, for example, of mild to moderate, so this is, here is it, mild to moderate, this is less than 4 to 6 movement of bowel per day. Mild to moderate rectal bleeding, no sign of systemic toxicity, normal CRP, normal ESR, absence of features suggestive of high inflammatory activity. These are the features of high inflammatory activity. Okay. This is the endoscopic score again, not going to review them. What does moderate disease? Moderate means more frequent bowel movement from 4 to 6 that may be loose and bloody, mild anemia not requiring transfusion, non-severe abdominal pain, minimal sign of systemic toxicity, and maintenance of body weight. Severe disease means frequent loose bloody stool more than 6 times per day, severe cramps, sign of toxicity, systemic toxicity, fever, tachypnea, hemoglobin less than 10, anemia, elevated CRP, ESR, and they define what does moderate to severe disease mean. And the entirety of acute severe ulcerative colitis is defined as more bowel movement per day more than 6, plus one sign of systemic toxicity, tachycardia, fever, anemia, or hemoglobin less than 10, or elevated inflammatory markers, the ESR is more than 30. Okay, we have to remember, and I said that the patient can move from one category to the another, from mild to moderate to severe. They here talk about these patients who are presented with mild to moderate disease. For example, patients with mild disease are less likely to need surgery or colectomy, so we can give a light type or smooth type of treatment, while some patients with severe disease we have to initiate the treatment with aggressive treatment to prevent the need for surgery. Okay, how we induce the remission, it depends when it's mild to moderate or severe. And the question appear here: The remission, is it clinical or endoscopic remission? And actually, we are talking about the clinical remission in induction of remissions, or we are talking about the clinical remission. Some data support the principal endpoint as a histological remission, but this is not our primary target. Our goal is to keep the patient glucocorticoid free clinical remission with mild to moderate disease. And to summarize, for mild to moderate disease, to induce the remission, we use actually the first two lines of our treatment. These are the 5-aminosalicylic acid, or we move to steroid by its different types. For example, we start by either sulfasalazine or mesalamine. It doesn't matter. We said that sulfasalazine have more side effect, but the recommendation says that any agent. But the idea is how we give them. It depends on the level of the inflammation. For example, we can give for induction of remission, we can give them as enemas. We can give them as suppositories. Actually, suppositories just reach the upper part of the rectum maximum, whereas enema can reach till the splenic flexure. We can induce our remission by the topical azathioprine. If no response, we can move to the oral, the tablet form of the mesalamine and sulfasalazine for induction of remission in mild to moderate disease. Of course, there is patient who doesn't respond. We can move to steroids. Then we have to move to steroids, and the steroids we start by, of course, according to the where is the affected part is. We can start by enemas of steroid. We have to remember that we should use budesonide for left-sided. If the left side is affected, or the colon, mainly the left side is affected, we can use budesonide. If no treatment for enemas or suppositories of steroid, we can move to oral type of budesonide. If no response to budesonide, we can move up to oral prednisolone. If no response or clinical remission doesn't achieved, we can give then biological agent or immunomodulator. But actually, for induction of remission in mild to moderate disease, we start by 5-ASA and then corticosteroid. We should remember that 5-ASA can be given as suppositories, as enemas, topical or oral, and then we move to steroid, budesonide, enema, suppositories, or oral prednisolone. Okay, about how we induce the remission in moderate to severe disease. In moderate to severe disease, the most important agent is the corticosteroid. Actually, the alpha ASA compound is not of a significant benefit in moderate to severe for induction of the treatment. Glucocorticosteroid, budesonide MMX, or the systemic corticosteroid are the agent used to induce a remission. Regarding the glucocorticosteroid, the immunomodulator haven't a great role in the induction of remission of mild to moderate or moderate to severe, because they are slow acting and not recommended. We said example of the immunomodulator is thiopurine and methotrexate, calcinurium inhibitor. These are not recommended. In the induction of a treatment, they take long time. Regarding the biological agent, yes, they recommend them in the induction of remission in moderate to severe disease, such as infliximab, adalimumab, golimumab, vidalizumab, are used to induce remission, and we will see that they are also used to maintain the remission. Okay, again to summarize: mild to moderate disease, ulcerative colitis, azathioprine corticosteroid. Moderate to severe, we use corticosteroids or biological agent. The immunomodulator doesn't play role in the induction, as they take longer time to have their effect. Severe or fulminant disease, how we can treat, and we have briefly to pay attention that patient with severe to fulminant disease, or we call them acute severe ulcerative colitis, ASUC, is defined as 6 or more bowel movement per day, plus at least one sign of the systemic toxicity, such as tachycardia, fever, anemia, elevated inflammatory markers such as the ESR. They are usually hospitalized. They are inpatient. We have to test for Clostridium difficile. We have to do at least flexible sigmoidoscopy to assess the disease severity and to check if there is no cytomegalovirus infection. Actually, the patient with severe fulminant colitis, 25 of these patients may 25 of patients with ulcerative colitis can develop or will develop to severe or fulminant disease, and of these patient with severe or fulminant disease, 40% will require colectomy. So it's not that easy. The induction of remission for severe to or fulminant acute severe colitis is the corticosteroid. Intravenous systemic corticosteroid is the mainstay of treatment. If no response, we move to calcinurium inhibitors. Such as cyclosporine. And we can move also to biological treatment in a form of infliximab or vidalizumab. So these are the 3 agents used to induce remission in acute or fulminant colitis. Corticosteroid, we started with corticosteroid. No response, we can move to either calcinurium inhibitors, cyclosporine, or biological agent infliximab and its brother. Okay, regarding the maintenance of remission, can we summarize the induction of remission? We said mild to moderate. We start with 5 aminosalicylic acid, topical, suppository, enema, oral. Then we go to glucocorticosteroid, topical, enema, suppository, oral steroid. In moderate to severe, no 5 aminosalicylic acid. In moderate to severe, we go to steroid, budesonide, prednisolone, no immunomodulator. They are slow onset. We go to either glucocorticosteroid or biological agent, such as infliximab. In severe or fulminant disease, to induce a remission, we go for IV systematic glucocorticosteroid. Not responsive, we move to calcinurium inhibitor, we move to biological agent. These are the induction of remission. The maintenance of remission, and with regard of the maintenance of remission, actually, for mild disease, to maintain a remission, we can use 5-alpha, 5-aminosalicylic acid compound, either topical or oral, especially those who respond to the induction of remission. We can use them. Glucocorticosteroid is not recommended for maintenance of remission. Immunomodulator for patient who doesn't respond to sulfasalazine or azathioprine, 5-alpha salicylic acid. Who doesn't respond, we can use immunomodulator. Immunomodulator, we said there are different agents such as thiopurine, which is recommended. Methotrexate is not recommended because it's a slow acting. Calcinurium inhibitor is recommended, and Janus kinase inhibitor is recommended for maintenance of a treatment. Actually, there are many table that example that guide our treatment according to the gastroenterologist guideline, but it's not our job. Okay, what's else? We want to say the biological agent. The biological agent is recommended for maintenance of the treatment in case of moderate to severe. I know it's not that easy, but as in the beginning, as I said, sorry, it's also difficult for me to be the treatment extremely depends on many factors, and to give one classic information is not an easy job. We reviewed how can we induce the remission. We reviewed how we can maintain the remission briefly. We have to remember that we have different form of each medication, suppositories or any man's oral. Actually, the dosing, the interval, how to follow the treatment, it's the interest of the gastroenterologist. I hope that I delivered the most important topics in an easy way. The conclusion, we said every single point. We now move to the medical treatment of Crohn's disease. Okay, and about the medical therapy of Crohn's disease, we said that there are many that shares with the treatment, the medical treatment of ulcerative colitis, but a difference also exists. If you remember, we said that in the treatment of ulcerative colitis, the curcumin or the homeopathic treatment, the probiotic is promising. Actually, the probiotics is not promising in Crohn's disease. The antibiotic, no rule in induction of remission in Crohn's disease. Yes, antibiotic can help us if there is abscess, if there is septic complication, especially in perianal disease, Crohn perianal disease, but no rule in the induction of the treatment. Diet. No proven rule that, or no proven benefit that it helps in Crohn disease. Fecal transplantation. If you do not hear about this item before, so it exists. We take the feces from a healthy patient and transplant it in a patient with inflammatory bowel disease. No proven benefit. Yes, there is a study that shows benefit in patients with pseudomembranous colitis and Clostridium difficile colitis, but no rule in Crohn disease. Okay. There is an item called exclusive enteral nutrition. Here is it. Exclusive enteral nutrition. Actually, we will find what does this mean in the few minutes later, but we found that this nutrition is beneficial in children, but no rule in adults. 5-amino salicylic acid. Not as good as in ulcerative colitis. Budesonide for induction. Not for maintenance of remission. Systemic steroid for induction of remission, not for maintenance. Thiopurine and methotrexate, the immunomodulator. Okay, these are not used for induction. We said that they are slow acting, but commonly used as for maintenance therapy, and usually they are used as a combination therapy with biological agent, not as a monotherapy, but we can use them as a monotherapy. Biological agent, we can use them for induction and for maintenance in moderate to severe disease. Biosimilars, we said that the biosimilars is the same as biological, but the advantage that they are cheaper. So they have no difference in efficacy or safety, but they have lower costs. Okay. Okay. Here the history that we mentioned in the beginning of our lecture about the Crohn disease. Here you can notice how the treatment differ according to the guideline that we mentioned. According, is it the AGA or ACG guideline? And both are correct actually, but we can see that the ACG is more comprehensive. Both of them are based on the severity. Of course, if we are talking about the treatment of Crohn disease, we are advising for smoking cessation and the use of antibiotic when for abscesses. Yes, you can see here that these are the AGA, ACG. Some medication are recommended in one school and another is not recommended. So it's not that easy to do the treatment or to establish the treatment for the patient, especially, and this is not my opinion actually, again, this is what's written, especially after adventing the biological agent. Okay, again, in details, antibiotic, no rule for induction of or maintenance. They are indicated for septic complication of penetrating Crohn disease. Remember that ciprofloxacin can cause tendinopathy, especially in elderly who take steroid. Metronidazole have role in the treatment of perianal disease. Again, treatment of septic complication, not induction nor remission. Probiotics, no diet, no fecal transplantation, as we said, for Clostridium difficile infection. Okay. Exclusive enteral nutrition, this is full liquid monodiet with nutritional supplement, which is proven for children, no rule for adults. Okay. Aminosalicylic acid, we said that have a good rule for mild to moderate disease and ulcerative colitis. And Crohn's disease, no. Actually, there is limited benefit of aminosalicylic acid. And we said aminosalicylic acid can be topical, so we can use them for Crohn's proctitis, and we said that the rectum is rarely involved in Crohn's, and in mild to moderate disease. Actually, some approve the drug, such as in Europe and in USA, it's not approved as a treatment for ulcerative, for Crohn's disease. Okay. These are example for patients who need aggressive treatment, and we will mention in a few minutes later that it's not, and again, it's like ulcerative colitis, it's not like a ladder. We should go step for step. We can jump up to the biological agent. We shouldn't wait until the complication develop, and this principle called target to treat. We will see it later. But these patients with high risk feature will indicate more aggressive treatment, and example of them, we mentioned them in ulcerative colitis. Young age, active smoker, penetrating phenotype, diffuse multifocal disease, ileitis, granuloma, perianal disease, and I think this pyramid is similar to that we see in ulcerative colitis. Okay, we talk about that. We talk about fecal transplantation, about, okay, again, we talk that isolated colonic Crohn, okay, Crohn proctitis, we said we can use ASA for it, corticosteroid. Okay, before that, the side effect and for ASA therapy, the side effect and especially the perioperative management, actually it has an excellent safety profile with regard of the preoperative management. We can start it, discontinue it before, after surgery with no problem. The side effect, we already mentioned them. We said that we should take folic acid when we treat the patient with sulfasalazine or with sulfasalazine. Okay, with regard of the glucocorticosteroid, okay, let's move a little bit down. Glucocortico steroid, we said that we have budesonide and we have systemic glucocorticosteroid, and we know that the budesonide have lesser side effect. An information that if the small bowel is affected, we can use the open capsule technique. I don't know, I'm not sure that you have to know that. And what I can also add to you regarding the stress dose, preoperative, before surgery and after surgery, should we have to give the patient steroid to avoid adrenal insufficiency, and should we taper it slowly? The budesonide is safe, budesonide is safe, no need for stress dose. Okay, regarding the systemic corticosteroid, what I can add for information? Okay, I think there are tables here. This is side effect of budesonide with long term. It's similar to the steroid, any steroid treatment. Systemic corticosteroid. These are the conversion table if we are taking prednisolone and hydrocortisone, if we want to take dexamethasone, methylprednisolone. So okay, we already covered most of them when we talk. These are the side effects of corticosteroid. I think we studied them in the medical school. Okay, about the immunomodulator thiopurine, we said that these do not work for induction. They are good for maintenance, especially for mild to moderate disease, especially who are steroid dependent, not used for induction. Also methotrexate, not used for induction, it uses for maintenance. And an information here, this is the also a table. We already see that the azathioprine is a precursor of 6-mercaptopurine. We already talked about that. Side effect of thiopurine treatment. Okay, we already mentioned most of them. Okay, this is table. Okay, yes, this is the thiopurine side effect. Pancreatitis, we talked about the idiosyncratic side effect, and we said if pancreatitis develop, we have to discontinue the medication. Okay, what I can else add? Information. If they say that if you are treating a patient with thiopurine and he underwent surgery, please do not resume thiopurine until the gastroenterologist review the patient. Okay, about the biological treatment also, as we said, it can be used for, this is the side effect of methotrexate. If you are interested, gastrointestinal, bone marrow, hepatic, pulmonary, renal. About the biological treatment, we said that we can use them for induction and maintenance, especially in moderate to severe disease. These are example of the tumor necrosis factor, infliximab, adalimumab, and the anti-integrin agent. Okay, what I can else, there is a table here about, just a minute. It's not a table, it's an important information here about the step up approach and the top down approach. And to make it simple, actually the step up approach, it's starting from the base of the pyramid and going up to surgery. And the top down approach, it is, for example, starting with biological agent or immunomodulator and down to and again, the top down approach is now advised, suggested, you can see here, suggested especially in a high risk patient. For example, and we already mentioned them, young patient, active smoker, penetrating, multifocal, granuloma. These, we shouldn't start with a simple medication and wait the complication. We should go for the top down approach. Okay, we said that in biological agent we have to follow and routine assess for tuberculosis, quantiferon test or TB gold test. Patients should be vaccinated against pneumococcus, varicella, human papillomavirus, influenza, hepatitis A, herpes zoster. Okay. We said that anti-tumor necrosing factor are used for maintenance and induction for moderate to severe disease. Anti-tumor necrosing factor actually, here are the anti-tumor necrosing factor actually are particularly important in perianal or rectal disease, in fistulizing Crohn's disease, in pyoderma, have a good role. The side effect we already talked about, it increases the opportunistic infection. We generally use the biological agent or anti-tumor necrosing factor as a combined therapy, especially with the immunomodulator and thiopurine. Okay. We have to mention that the biological agent can develop or lose the response due to anti-drug antibody. So we routinely test the drug level or the ADA, anti-drug antibody. So the loss of responsiveness is one of the side effects, and it prevents its future use, especially if we are planning to discontinue them. If the patient have long-term clinical remission and we want to discontinue them, here is a question, they may not respond in the future. Okay, also they talk about vedolizumab. Actually, we already covered these topics in ulcerative colitis. We talked about biosimilars. Principles of induction. When we want to induce the remission in ulcerative colitis, in Crohn's disease, this is actually depends on the location. And again, it is divided to mild to moderate to severe. If we are talking about mild Crohn's disease that is limited to the terminal ileum, we can use budesonide to induce the remission. And we know that for if it is mild colon, we can use 5-ASA or steroid. If it is upper GI, we have to use steroid and immunomodulator. Okay, if it's aggressive, so biological treatment is advised. Again, mild, we use mainly budesonide or 5-ASA according to the location. Moderate, budesonide, steroid or steroid with immunomodulator, or please, the principles of induction in Crohn's disease is to go early for biological agent or even surgery. We do not wait the complication. Okay, if we are talking about the colon, we can use steroid in moderate disease. We can use combined or monotherapy. Combined therapy such as steroid and immunomodulator or biological and immunomodulator for induction. Severe, we are talking about steroid or combined biological and immunomodulator. Please consider early resection. And if we are talking about upper Crohn's disease, we are giving combined steroid and immunomodulator, and by the way, they will take them for the rest of their life. This is what I want to talk about, the principles. Okay, we covered that, we cover it. Principle of induction, we talk about mild, moderate, target to treat. Target to treat, the principles of maintenance therapy. We said that classically we start in a step up approach or escalating approach, but target to treat, it is more aggressive treatment that is guided by what? By subjective and objective parameter. We also look for example, the objective sign of inflammation for blood and stool chemistry. We look for fecal calprotectin, CRP, imaging, endoscopy. Even the patient is doing well. So the combination of these, if it's aggressive, we go for more aggressive treatment. And this is what does target to treat. It is try to control the symptom according to the objective and subjective sign to prevent progression of bowel damage. Okay. In a form of what? In a form of fistulizing fibrostenosis penetrating disease. Okay. Again, if we are of the general principles when treating Crohn disease, if the patient is on maintenance and if the patient is maintain the remission and of steroid, please, and weaning of steroid, please, no treatment for 6 months and give the endoscopist to reevaluate the patient. If we have isolated disease according to the target to treat, means aggressive treatment, go for surgery. Go for surgery. Do not give medication, and you have to offer the patient a referral to surgeon. Okay. What else we can add to you? We said that the biological treatment is good for induction, and if we receive, especially in moderate to severe, and if we achieve induction with biological treatment, please continue it for maintenance. We generally use biological with immunomodulator as a combined therapy. Again, regarding the tumor necrosing factor, anti-tumor necrosing factor agent, antibody to drug can develop or appear, and the treatment in responsiveness can be an issue. So we have to check the antibody for this drug. Okay. What else? To avoid immunogenicity, if no response, so there is lack of response or low drug concentration or development of antibody. De-escalating, it's mentioned here. I think de-escalating means moving from up to down, or it's moving from combined therapy to monotherapy, or withdrawal the medication completely. As we mentioned before, in biological agent, please be careful. If we stop it, drug resistant may develop, limiting its use in the future. We shouldn't de-escalate or remove the medication, even the patient in a deep remission, in patient with penetrating disease, in patient who underwent surgery, or these patients who are on anti-tumor necrosing factor agent. When we want to de-escalate, we have to have deep clinical remission. We have to have normal biochemical markers, CRP, SR. We have to have normal histology and normal imaging. Okay. We have to remember that patients who undergo ileocecal resection will require additional surgery in a 50%. Half of the patients who undergo ileocecal resection will need surgery. After ileocecal resection, we have to do surveillance endoscopy every 6 to 12 months. Okay. Actually, we finished the medical treatment of Crohn's. It's a little bit similar to ulcerative colitis. We said how we can maintain the remission, we induce the remission. Absolutely, it's not an easy job. It's guided by two schools, and as I said, the surgeon should know it, as he will take the lead. He will be the leader, especially in the perioperative period. I hope I delivered the information in a simple way. Actually, do not worry about what's written over here. I already read this text more than 10 times, and I wrote my own notes, and I delivered the most important topics that you should know. Now we are going to talk briefly about the anorectal Crohn's disease and the surgical management of ulcerative colitis and Crohn's disease. Okay, and about the anorectal Crohn's disease, we are talking about a key concept or the general concepts. So first of all, I think we have to mention what does this mean. Actually, anorectal Crohn's disease are divided to fistulizing and non-fistulizing disease. Fistulizing, this is the fistula and abscess, and non-fistulizing Crohn's disease such as hemorrhoid, tag, skin tag, fissure, ulcer, stricture, cancer. So, in the management of these patients, we have first of all to control sepsis. What does this mean? If we have abscess, we should drain it. We have to address the infection before starting immunosuppressive medication. We have to keep in mind that initially we should treat the luminal disease. If the patient have proctitis, treat them according to what previously mentioned. If the patient have diarrhea, so give him antidiarrheal agent. No steroid in perianal Crohn's disease. Perineal care, like what in the treatment of anorectal disease, like hygiene is important. Zits bath, skin protection. There are certain creams called the barrier creams. We have to avoid surgery in patient who is asymptomatic first, or one, and two, in patient who have active proctitis. Okay. Actually, the treatment of the perianal or anorectal Crohn disease is a little bit similar to general population, except that we try to delay surgery, and we can use some biological and immunomodulators for certain condition. For example, the fistula, we actually use ceton as a long term, even permanent ceton. We do not use fistulotomy, for example, or it's better to say we avoid fistulotomy. Okay. If there is a skin tag, this is what's written in the general concept over here. If we have a skin tag or hemorrhoid that is asymptomatic, leave it. We said hygiene, diversion. Even we can do end colostomy to divert the stool from the affected area. Okay, as we said, perianal, in the introduction, perianal skin disease, perianal Crohn disease are divided to fistulizing, fistula and abscess, and non-fistulizing, such as hemorrhoid, tag, fissure, ulcer, stricture, and malignancy. About 30% of patients with Crohn disease have perianal involvement. About 80% of them require surgery, eventually require surgery. Okay. Fistula is a common, about 80% of the perianal lesion. About 10% of patients with Crohn disease, their initial manifestation will be fistula. Okay. They said also 5% of these 10% who present with fistula as the sole as the sole manifestation of Crohn disease, 5% of them remain isolated. Patient with Crohn disease that is manifested as fistula. The biggest risk factor for development of fistula is the distal involvement. The more distal involvement, the more likely to develop fistula. For example, involvement of the rectum and anus versus involvement of the small bowel. Of course, we have high recurrence in compared to normal patient with fistula. Okay, the abscesses, actually the classification is similar to abscesses in general population. These are perianal, ischiorectal. If we have a separate lecture for abscesses and fistulas, but ischiorectal is the most common, about 40%, intersphincteric and suprasphincteric. And the management of abscesses, we said control sepsis, surgical drainage. Ischiorectal abscesses, if you watch the lecture about abscesses, we can drain it by cruciate incision, but it's preferred that this incision will be closed to the sphincter or close to the anus. So if a fistula developed, the tract will be short. Intersphincteric, we can do transanal or transrectal incision. After penetrating the internal sphincter, we reach the intersphincteric space. Okay, if we didn't, and sometimes we cannot determine where is the abscess, especially intra-op at the time of examination under anesthesia, we can use needle aspiration. If we have large abscess, we can put a drain, mushroom cath called, so like with a head. At the time of drainage of an abscess, if a fistula was identified, do not do fistulotomy, even if it's low. What you can do for PEST is to do ceton, to put ceton. Okay. This is about the abscesses. If we are talking about the fistula, so the definition of fistula is a chronic tract of a granulation tissue connecting two epithelial line surfaces. The fistula is actually between the anorectum and different side. The fistula can be to the perianal, to the buttocks, perineal, inguinal region, to the vagina, to the urinary tract. The fistula can be classified to complex and simple fistula. Here it is complex and simple fistula. For example, and by the way, 80% of fistula in Crohn's disease are complex. What does simple fistula mean? These are low lying or superficial, low intersphincteric or low transsphincteric, they are simple, single tract opening, not multiple or branching. There are no pain associated, no coexisting abscess. It's not rectovaginal and there is no structure associated with it. If these are met, so it's simple. So what does complex mean? High transsphincteric or extrasphincteric, multiple opening or branching, coexistent of abscess, rectovaginal fistula, stricture, or active rectal proctitis, active rectal disease. These are called complex fistula. How we diagnose it? It's a multimodal. It's a matter of physical exam. It's a matter of EUA. It's a matter of imaging. And we remember that pelvic MRI is the best. Okay. About the management of fistula in Crohn's disease. First of all, if there is an abscess and we drain it, please go for endoscopy, colonoscopy, to assess for the proctitis, because proctitis will contraindicate our surgical management. And actually, it's medical treatment and surgical treatment for fistula. Similar a little bit to the management of ordinary or traditional fistula. Regarding the medical treatment, we have antibiotic, and antibiotic can be used as a bridge to immunosuppressive medication, or in a combination with it. Of these antibiotics are the ciprofloxacin and metronidazole. And we can use also infliximab and azathioprine. But these modalities are of high recurrence. Okay, we say thiopurine and 6-mercaptopurine are these medication of immunomodulator are best in combination with anti-tumor necrosing factors such as infliximab. Okay, we said calcineurin inhibitor and biological agent also we can use such as infliximab, tacrolimus, cyclosporine. These are according to the study better for reclosure and recurrence. The surgical management, we can start by fibrin glue and plugs. They are usually used for multiple branching or as an adjunct with other modality of the treatment. We can use ceton. It should be loose and it may be permanent. It may be for days, months, years, or even permanent. A modality of a treatment is a stem cell therapy. which is interesting a little bit for fistula. Fistulotomy in absence of proctitis. We can consider it. Advancement flap, endorectal advancement flap, also without active proctitis, and ligation of the intersphincteric tract, also a modality of treatment. Okay. They prefer the cephon for chronic disease and the use of infliximab for the treatment. We should remember it may be the medical treatment may be monotherapy or combined therapy. The rectovaginal fistula, one of the complex fistula, rectum, vagina, or anovaginal. It presents in female with the Crohn's disease in 10%. It's the more distal, the more rectovaginal, more in colonic involvement. Some have no symptoms or minimal symptoms. The symptoms are seepage, incontinence, UTI, sexual dysfunction. Treatment actually of the rectovaginal fistula is advancement flap from the anal side or vaginal side. Some modality of treatment is interposition of a gracilis muscle or the pulpocavernous called Martius muscle. Polythrow procedure, fibrin glue, stem cell, mesh interposition, or are modalities for treatment of rectovaginal fistula. Of the non-fistulizing complication, we said fissure and ulcer. And we have to remember that in Crohn's disease, the fissure can be idiopathic, which is the most common, which is present in posterior in 90%, anterior in 10%, or atypical. Other than the location, the atypical is usually off midline, not on the midline, neither anterior nor posterior. But another important difference that the idiopathic is associated with high anal tone. So left internal sphincterotomy is advised to relax the anal tone, while the atypical fissure have normal anal tone, so they will not benefit from sphincterectomy. Okay, we can use the modality for treatment of fissure. We can use first of all, we have to treat the luminal disease. Luminal mean proctitis, the distal disease, the ulcerative colitis itself, the Crohn's disease itself. We can use psyllium husk if there is diarrhea. We can use topical agents such as nitroglycerin or calcium channel blockers, botulinum, topical metronidazole, cyclosporine, local infiltration of infliximab, and also hypertonic O2 have a role. Okay, the gold standard for treatment of fissure is systemic anti-inflammatory, anti-tumor necrosing factor. Anopractictomy if cavitating ulcer. Actually, I didn't insert intentionally. I didn't insert pictures because, these pictures are not extremely beautiful. Okay, regarding the tag, and there are two types of tag. One is painful, the other is painless. Painless called the elephant ear tag, while the painful is usually due to fibrosis, ulcer, hemorrhoid, lymphedema, secondary to obstruction. Actually, again, tag if asymptomatic, leave it. But usually they are large enough to cause irritation and problem. Hemorrhoid present in about 20%, and they are generally treated medically. Okay. And also about the treatment of stricture in Crohn's disease, actually they follow the treatment of stricture in a normal patient: dilatation, advancement of flap, and even proctectomy. Anal cancer, please think if there is fistula that is for long term asymptomatic and suddenly becomes symptomatic. It may be malignant fistula. The risk is high for both adeno and squamous carcinoma. And the diagnosis is by biopsy. And the treatment of anal cancer in Crohn's disease is same as sporadic. We said that we can do even diversion in a form of endocostomy and proctectomy to provide perineal hygiene, or if the fistula we cannot deal with it, or as a last resort we can divert the stool from the perineal and pelvis, and as permanent or temporary. Okay, now we move to the surgical treatment. Dear colleagues, we now going to talk about the surgical management of Crohn's disease and ulcerative colitis. And if we start with Crohn's disease, so it's as I mentioned in the beginning of this lecture, that inflammatory bowel disease is the interest of colorectal surgeon, and some colorectal surgeons are interested in inflammatory bowel disease, and they are called IBDologists. Why I mention that? Because they know well the optimal timing of surgery to achieve the best outcome. It's their responsibility. And also in the past, there was a trend toward the resectional surgery and the achievement of microscopic negative margin. Nowadays, we apply what we call the bowel sparing principles to preserve the bowel length as much as we can from the bowel length. Of course, without compromising the long-lasting remission. Also, the need for surgery is declining these days, and this is because of the adventing of the new class of medication, such as the biological medication and the immunomodulators. Many patients wishes that they have or they undergone their surgery earlier in their disease course because of the result of surgery was good. Okay. Regarding the indication for surgery in Crohn's disease, they are summarized in this table: failure of medical treatment, and this is a general term. We will see what does it mean. Pediatric growth retardation, bowel obstruction, free perforation, penetrating disease such as fistula or abscesses, cancer, dysplasia, toxic colitis, and bleeding. Okay, regarding the first indication, failed medical therapy, as I said, it has many definitions. Actually, this is a general term. It can be failed medical treatment. For example, we cannot achieve acceptable symptoms despite escalating or combination of the therapy. The patient is not responding to treatment, or the patient cannot tolerate the side effect of the treatment. In pediatric age group, failure to growth is a reflection of failed medical therapy. Regarding the steroid treatment, refractoriness and dependency is an indication for surgery. The steroid refractory means that the steroid is not controlling the symptoms. And the exact definition for steroid refractory you can see here. It is active disease despite prednisolone 1 milligram per kg per day for 4 weeks. So we are giving high dose of prednisolone for long period and the disease is still active. Or steroid dependency, that means that we cannot stop the steroid, and it means a patient who are not able to decrease the dose below 10 milligram per day without reactivation, or those who relapse within 3 months after stopping the steroid. These are the indication or what does failed medical treatment therapy. Again, unable to achieve acceptable symptoms despite escalating or combination, side effect of the treatment, failure to growth, steroid refractory, and steroid dependency. Okay, regarding the bowel obstruction, about 1 out of 4 of Crohn's disease surgery are due to obstructive causes. Recently, at this time, we have no medication that can deal with the stricture and the fibrosis that is found in Crohn's disease. Other obstruction can be due to stricture, and we will see that stricture can be fibrotic stricture or inflammatory stricture. But other causes is the anastomosis, where the anastomosis happened, the anastomotic stricture, and neoplasm. Okay, actually here they talk about the how can we pick the stricture. Mostly they are in the terminal ileum. As we mentioned, they are best found on CT and MR interrography. There are different features on CT and MRE to differentiate between fibrotic stricture and inflammatory stricture. But I don't think that you have to remember why we have to distinguish between the two, because the inflammatory stricture, you see in fibrotic stricture there is pre-stenotic dilatation. In inflammatory stricture, they are most likely to respond to medical treatment. If we need surgery here, so we need ileocecotomy, and by the way, ileocecotomy have a high rate of controlling the disease. Is there any rule for balloon dilatation? Yes. Endoscopic balloon dilatation, especially for short segment, means less than 4 centimeter, or at the anastomotic structure, we can use balloon dilatation. Of course, balloon dilatation cannot be done if there is a marked angling of the small bowel. It will be hard, or if there is concomitant abscesses or fistula, so we cannot proceed for dilatation. Technical wise, the dilatation should be at least 14 millimeter or 1.5 centimeter. Optimal to do the dilatation up to 16 to 18 millimeter. This is associated with less frequent follow-up procedure, and above the 2 centimeter, above 20 millimeter, there is a risk for perforation and bleeding. Of course, multifocal, multiple structure is risk for failure in balloon dilatation. Okay, regarding the perforation, in Crohn's disease, actually it's rare. It's associated with toxic colitis and multiple structures. Actually, if we have multiple structures or two structures in two different sites, we will have what we call it closed loop, and the intraluminal pressure will increase, and this will lead to perforation. So toxic colitis and multifocal structures is a risk factor for perforation. The best treatment for perforation is resection and primary anastomosis. We have to apply the principle bowel sparing. What is macroscopically, what we see diseased, we remove only. Perforation can be in the small bowel, can be in the large bowel. If the perforation in the small bowel, mostly to be proximal to the site of the structure. If it is in the colon, mostly to be in the cecum. So in small bowel, we do resection and anastomosis. In the colon, if we have perforation, the cecum is mostly affected or pending perforation. So the gold standard surgery is total abdominal colectomy with ileostomy. And the rectum is left stapled and left in the pelvis. We do not remove the rectum. So we have three scenarios actually. In the small bowel, resection and anastomosis. In the colon, total abdominal colectomy and ileostomy. And if we have toxic colitis, also we proceed to total abdominal colectomy plus ileostomy, and ileostomy, that's the same. Okay. About the penetrating disease, we said that these are fistula and abscesses. It's about 10 to 15% of the disease. Tobacco is a risk factor for penetrating disease in Crohn's disease. The penetrating disease or fistula can be enterocolic. This is the most frequent, enterocolic. In a lesser degree, enteroenteric. In a lesser degree, enterocutaneous. In a lesser degree, rectovaginal. Enterovesical. Enterosalpingeal, and enterogastric. The origin is mostly the terminal ileum or the ileocecal, mostly the terminal ileum. Only symptomatic fistula need surgery. What are the symptoms? Actually, these are nutritional symptoms and diarrhea if we have bypass of the stool from the ileum to the sigmoid, for example. Okay, how we treat fistula? Actually, we have the origin of the fistula and the targeted organ. For example, enterocolic, we have the small bowel. This is the origin of the fistula, and the targeted organ is the colon. So the disease segment or the origin, we resect it and the primary anastomosis. But the targeted organ, we just do primary repair. For example, if it is enterovesical, okay, we resect the small bowel, we resect the fistula, and we repair the UP, the urinary bladder. We can do primary repair, we can use patch for closure. Some of the penetrating fistulas can present as psoas abscesses, and psoas abscesses can be treated with antibiotic, plus steroid. Can we go to percutaneous drainage if it is above 3 centimeter and accessible? Uh, of course, many talk about this is a type of fistula, enteric fistula. Most of the fistulas are found intraoperatively. They are not picked up before the surgery. This is an abscess. Okay. Okay, about the percutaneous drainage for psoas abscesses that can present in Crohn's disease as a complication of fistula to the retroperitoneum, we said percutaneous drainage, and many studies regarding is percutaneous a definitive surgery or just bridging to surgery. You do not need to know more than that. Okay, cancer and dysplasia in Crohn's disease. Okay, and I guess that you know that cancer and dysplasia in Crohn is lesser than the risk of cancer, and so is lesser than in ulcerative colitis. The risk for cancer is increased for both intestinal and non-intestinal cancer. Is there any difference between the sporadic and colitis associated cancer? On the genetic level, they said that, for example, the APC gene mutation loss, which is early in sporadic cancer, it presents late in colitis associated cancer, while B53, which is early in sporadic cancer, which is late in sporadic cancer, it's early in colitis associated cancer. Okay, genetic differentiation. Okay, we said that the risk is increased 2 to 3 fold comparing to general population, and the mean age of diagnosis is about 50 years. And this is 20 years before the normal population. The cumulative risk after 10 years of diagnosis of Crohn's disease, it's about the risk of cancer is about 3%. After 20 years, it's about 6%. And after 30 years, it's about 9%. We add 3 every 10 years. Then, after 10 years of Crohn's disease, 3% risk of cancer. After 20 years, 6%. And after 30 years, it's 9%. Okay, one of a recognized risk factor for cancer and Crohn's disease is smoking, and also smoking for fistula, and also smoking for the need of surgery, if you remember when we talk about smoking, and also stricture, and especially the short stricture. These are called malignant stricture. Actually, the surgery the surgery for cancer and dysplasia, it's the same as in ulcerative colitis. We will discuss it in a few minutes later. Okay, we are now going to talk about toxic colitis. Okay, with regarding of the toxic colitis, we said that toxic colitis actually is severe colitis plus imaging demonstrating megacolon. And severe colitis, we define it according to the true love and wet criteria. If you remember, 6 or more bloody diarrhea plus sign of systemic toxicity. Okay, we start, how do we treat toxic colitis? First, we start with medical treatment. If you remember from the previous section, we said that they are first hospitalized. They need to rule out Clostridium difficile infection and cytomegalovirus infection. We have to do DVT prophylaxis, pain medication, and medical treatment. If that failed, we proceed to surgery, and our surgery in toxic colitis is total abdominal colectomy plus end ileostomy plus minus mucus fistula. Okay. Mucus fistula, actually, it's bringing the rectal stump percutaneously as a mucus fistula. Regarding the bleeding, bleeding is rare in Crohn's disease. It's about 1%. Bleeding in Crohn's disease is focal due to focal erosion of the intestinal vessel or due to pseudopolyp. It's important to localize the bleeding, and it's important to remember that about 30% of the bleeding is from the upper GI, duodenal ulcer bleeding. The principle of how to manage bleeding is the same principles as in sporadic lower GI bleeding. We have a lecture for lower GI bleeding. What we can mention in bleeding in Crohn's disease, that early colonoscopy is important within the first 24 hours. Okay, let's move to some. This is how CT angiography and extravasation looks like for an unstable patient. This is well covered in the lecture of lower GI bleeding. Some surgical consideration. Okay, here they talk just what we mentioned in the beginning of our lecture, that surgery and Crohn's disease is palliative. In the past, we used to do margin negative resection. We are worried about the margin that it is negative, but nowadays we apply the principle bowel sparing approach or non-resectional technique. Like what? Like structuroplasty. We will see in a few minutes. Despite or instead of resection, we do structuroplasty and we preserve the bowel length a little bit. Regarding the nutritional support and TP, and we already talked about that, exclusive enteral nutrition is beneficial in pediatric age group for induction and maintenance of remission, but in adult, some studies said that it may maintain remission in mild form. Okay, patient benefit from total parenteral nutrition, especially if they have sign of significant malnutrition, and these are defined as, where is malnutrition? They are defined as weight loss above than or more than 10% within 3 to 6 months, or this is first, or I can't find where is it here in the text, but it's definitely written somewhere here. Here it is. Okay, as we said, malnutrition, weight loss more than 10% within 3 to 6 months, or body mass index less than 18.5, or albumin less than 30 gram per liter, this patient will benefit from peri-op nutrition. Okay, let's move a little bit for the overview of operative consideration. And here they discuss about the benefit of minimally invasive surgery. Minimally invasive surgery can be in a form of laparoscopic surgery, can be in a form of robotic surgery. And what we have to remember that if we have septic complication, phlegmon, inflammatory mass, so the risk of minimally invasive surgery, the risk for injury is high in minimally invasive surgery. Of course, if we are talking about laparoscopic or robotic surgery, so we lost the property of feeling the bowel, the tactile feedback. We do not feel the bowel. So this is sometimes important to differentiate, for example, malignant or benign fistula. So limited tactile feedback, but the study found that it doesn't matter and it doesn't apply a big disadvantage that we limit our tactile feedback. Minimally invasive surgery in a form of laparoscopic or robotic have better pulmonary function, recovery, less morbidity, less length of stay, less hernia risk, and better cosmetic. One of the things that we have to consider in laparoscopic surgery and robotic surgery that in Crohn's disease we have a thick mesentery, inflamed mesentery. Sometimes it's hard to divide it by the laparoscopic vessel or the vessel sealing device. Sometimes it's hard to do anastomosis or even hard to bring the bowel out because of the thickened mesentery. Okay. Also here they talk about the complex Crohn's disease and they defined it as those patients who has phlegmon, who have previous operation, abscesses, fistula, or on immunosuppressive medication. These can undergo minimally invasive surgery, but with high risk of convergent to open. Sometimes they use the hybrid procedure. Hybrid procedure means we do laparoscopic surgery or robotic surgery for part of surgery, and the remainder of surgery we proceed with open surgery. Okay, regarding the robotic surgery or robotic minimally invasive surgery, the morbidity and the length of stay is decreased even compared to laparoscopic, but the operative time is increased even compared to open or laparoscopic. There are many techniques mentioned here, for example, the single incision, one incision in laparoscopic surgery. We talked that there is hybrid combined laparoscopic and open or open surgery. Okay, one of the concern is where to do the anastomosis, inside the abdomen or outside the abdomen, intracorporeal or extracorporeal anastomosis. Also, nothing, just we have to remember that something like that exists. Regarding the enhanced recovery pathway. Okay. And enhanced recovery after surgery or ERAS is long with many details subject to talk about, but we have to remember that inflammatory bowel disease is a risk factor for prolonged length of stay. We have minimal data regarding if enhanced recovery after surgery or ERAS is beneficial in inflammatory bowel disease, but in general we can apply the principles of enhanced recovery after surgery for inflammatory bowel disease. I think we will have separate lecture about enhanced recovery for colorectal diseases in the future. It's actually when to start antibiotic, how to manage patient regarding DVT prophylaxis, when to start the oral diet, when to stop the oral diet before surgery, different component, but in general we have low data, we have minimal data. As I said, inflammatory bowel disease is a risk factor for prolonged length of stay, which is one of the subject of ERAS, is to decrease the length of stay and to decrease the morbidity of the patient. Regarding the peri-operative management, our concern in Crohn's disease is the steroid. Many patients are on steroid, and the question appear here: do we need to taper the steroid before surgery? We know that steroid is a risk for adrenal insufficiency. It's a risk for wound complication. Do we need to stop them or not? Do we need to give stress dose or not? This is also a complex question. It's not. I do not want to deliver the information. Even in the textbook, if you read it, it's extremely complex, and I'm trying to deliver for you the conclusion. For example, if the patient is not taking steroid the last year before surgery, so he doesn't need a stress dose. The crisis, the adrenal crisis, or the hypothalamic pituitary adrenal axis suppression doesn't. Some study that found that it doesn't depend on the dose and the duration of steroid. So, okay. We said also about tapering. If we are going to elective surgery, so we try to wean steroid 1 week before the surgery, or make it at least less than 20 milligram of prednisolone per day, or it's equivalent. Okay, I can here. A study found that patients treated within the past year do not need steroid, and even those patients who was treated within the past year, we said that who do not take steroid for the past year do not need any stress dose. But another study found that even those who are treated within the past year do not need stress dose, do not need additional dose to avoid the crisis, because they found that all hypotension, bradycardia, tachycardia, which is the manifestation of adrenal crisis, resolve spontaneously. Okay. The high dose is also concerning regarding the impaired wound healing and the infection. Okay. This is regarding the steroid. Actually, we will have a separate lecture about the perioperative management, and there is a table I have for how to do or how to manage the steroid perioperatively, and this will depend on is it major surgery, minor surgery, what is the dose before the surgery the patient is taking. In this textbook, and regarding the inflammatory bowel disease, we said in this textbook they do not recommend the stress dose. They advised to taper or at least minimal steroid before surgery and to observe the patient post-operatively. Okay. This is regarding the steroid. Regarding other medications, such as if the patient is taking immunomodulator, 6-mercaptopurine or azathioprine, they are safe. They are safe to continue pre-op and discontinue it at the morning of surgery, at the day of surgery. Okay. Other also regarding the infliximab, we have to stop it 4 weeks before surgery. Vidalozumab, we have to stop it 6 weeks before surgery. Ustekinumab, it's safe. Okay. A table here exists about the risk factor for post-operative septic complication. For example, corticosteroid use, malnutrition and hypoalbuminemia, anemia, blood loss, emergent surgery, anti-tumor necrosing factor. We said that infliximab should be stopped 4 weeks, 1 month before surgery. Vedolizumab, I hope the pronouncement is correct, we have to stop it 6 weeks before surgery. And ustekinumab is safe. Okay. Other risk complication, vedolizumab, penetrating disease, recurrent disease, and smoking. These are risk for septic complication post-op. Okay, let's move to the anastomotic type. We said that we do resection and anastomosis, and the question appear here. What type of anastomosis? There are mainly 2 types, and we added 3rd type. We will discuss it in a few seconds. These are the end-to-end. Do we approximate the bowel end-to-end or side to side? Yes, end-to-end or side to side. And the 3rd type is, we call it the conotype or conoas. I will show it to you. And in summary of what's written here, it's actually the different type are studied regarding its leak and leak risk and recurrence of the disease risk. And an important factor for the anastomotic type is the surgeon experience. It's important. If we want to compare the side to side to end-to-end anastomosis in Crohn's disease, so the studies found the most important, of course, the surgeon experience, but the study found that leak and post-operative complication and recurrence is less in side-to-side anastomosis when we compare it to end-to-end. So what is now conotype? Conotype is, I think, discovered in 2011. Not discovered, but invented. It's actually a type of anastomosis that is hand-sewn, anti-mesenteric, end-to-end anastomosis, and the aim for it is to decrease the recurrence. Actually, you can see here that the structure is resected, and they did an end-to-end anastomosis. They did enterotomy in both sides, and they close it in a continuous fashion, and this will be the final result. This is what we call it conotype. In summary, no superiority of one over the other. The most important is the surgeon experience, and we said that we have, according to the study, they support the side to side, and the conotype found also to be beneficial regarding the recurrence, lower recurrence. Okay, this is regarding the anastomosis. We are now going to talk about the disease, recurrence, and surveillance after. And here, if we are talking about the surgery, so it's mainly with the ileocecal resection, the most diseased part. So recurrence on endoscopy after 1 year of resection of the ileocecum is about 70 to 90% high. And those who need additional surgery is about 30%. So within the 5 years, the following 5 years. The risk factor for recurrence, especially at the anastomotic site, is fecal stasis and altered microbiome and local ischemia. These three things will make the recurrence in the anastomotic site higher than usual. One study found that biological treatment after surgery is associated with lower recurrence rate. Okay, regarding Crohn's disease and special location, if we are talking about, for example, the upper GI, the gastroduodenal disease, so it's rare, it's less than 1%, and about 2/3 of the patients are asymptomatic, and 90% the disease coexists with distal GI Crohn's disease. Most commonly, gastroduodenal disease and Crohn's disease or gastroduodenal location in Crohn's disease to be affected by stricture, which will present like stati, emesis, and postprandial pain. The fecal calprotectin doesn't play a role here, such as in the distal Crohn's disease. Of course, gastric Crohn's disease differ a little bit from duodenal Crohn's disease if you are interested. So this is, for example, stricture, I think, duodenal stricture on MRI. And gastric Crohn's disease is characterized by aphthous ulcer, longitudinal ulcer, bamboo joint-like appearance, and duodenal ulcer is a notch-like erosion of Kirk ring. I don't know where are they here. Actually, I think they are mentioned somewhere here. Here are them. Aphthous erosion, longitudinal ulcer, and bamboo joint-like appearance in the cardia are characteristic for gastric Crohn, while longitudinal and notch-like erosion of Kirk ring fold characterized for duodenal Crohn disease. Okay, let's move a little bit. Okay, the treatment of gastroduodenal inflammatory bowel disease is the same as distal Crohn disease, plus acid suppression, the PPI. What else we can add here? That surgery is less than 1% of all surgery for Crohn disease, and mainly they are due to obstruction and fistula. And the fistula mainly comes from the terminal ileum and a little bit from the transverse colon. From the terminal ileum goes to the duodenum or stomach. We said that the terminal ileum we resected, ileocecal resection, and primary repair of the gastric or duodenal ulcer, we can use the serosal jejunal patch. We can use balloon dilatation for short segment. Okay. Okay. Here also appear the question, if a structure exists, do we need to do, in the duodenum especially, do we need to do structuroplasty or bypass surgery? And actually this is depend on the location of the structure in the duodenum. For example, if it is in the first or fourth part of the duodenum and there are more than two structures, so we can do bypass. For example, gastroduodenal bypass, gastrojejunal bypass, duodenojejunal bypass. And we said this is regarding the bypass surgery. And structuroplasty, we will see in a few minutes. This is mainly the hinky mucolis or fine, especially if they are in the second or third part of the duodenum. It's important to know, is this a malignant or benign structure? Sometimes we cannot know, and we do bypass, and third of the patient, 1 out of 3 of the patient require surgery for malignant or recurrence or marginal ulcer. Okay, I know that you are interested now to know how does structuroplasty looks like as a mode of treatment for structuring in duodenum. We are going now to talk about them, about the upper and upper small bowel disease. This here we mean the jejunum and ileum, but not the terminal ileum. Also, they are rare. They are 3 to 10%. The most common indication in the upper GI or the upper small bowel disease is obstruction or sepsis. In a lesser common indication for surgery in jejunum and ileum is hemorrhage and carcinoma. We said that resection changed from microscopic surgical margin to macroscopic surgical margin, or even structuroplasty, which we mean by bowel sparing surgery. We worry about in the upper small bowel disease or the small bowel in general about the short bowel syndrome. If we are going to do surgery for small bowel, please check proximal and distal site of the obvious structure, because we may have other structure coexisting proximal and distal. How can we check? A catheter, cuffed catheter introduced intra-op. Okay. Here we said that fibrotic structure, not inflammatory. We said inflammatory, it can respond to treatment. Fibrotic structure plus luminal diameter less than 20 millimeter or less than 2 centimeter is an indication for surgery. What type of surgery? It can be resectional or bypass. Okay. Intraoperatively, we have to document the location of the structure and the length of the structure because in the future we should have a documented information about the length of the bowel. Structuroplasty, I know you are a little bit interested. Structuroplasty, we have different type, and this is guided by the length of the structure itself, and the risk for developing blind loop syndrome. To make it simply, any structure that is less than 10 centimeter and appropriate for structuroplasty, so Henke-Mikulai's structuroplasty is the appropriate. And by the way, it's the most common. What does Henke-Mikulai's stand for? It's actually very simple. You can see here that there is a structure which is short, less than 10 centimeter. Actually, we cut the bowel, or we do a longitudinal enterotomy, and we close it transversely. What will happen? The luminal diameter will increase. This is Henke-Mikulai's structuroplasty. If the segment is longer than 10 centimeters, so we go for either Fine or Gipoli. Fine is, I hope the pronouncement is correct, it's indicated for a structure that is longer than 10 centimeter and less than 25 centimeter. Here we have a risk of blind loop syndrome. We have bacterial overgrowth here. Actually, as you can see, they open the bowel side to side, so the afferent limb and efferent limb is one lumen, become one lumen, but here we have a risk for blind loop syndrome to develop. Gipoli is similar to Fine, except they are not connected the whole way between the afferent and efferent loop. They are just connected in a proximal part called lateral diverticulum. What they do artificial lateral diverticulum. This is Gipoli procedure. The indication is the same. Any structure between 10 to 25 centimeter, and the risk for developing blind loop syndrome is significant in this. Other type of anastomosis is the side-to-side isoperistaltic. Simple and easy. It's actually bringing up two side of the bowel and making them one. I don't know how I'm making them one limb. It's indicated for structure that are more than 10 centimeters, like that, closing this part of the lumen and this part and making it one lumen. This is called side-to-side isoperistaltic structuroplasty, indicated for any structure above 20 centimeter. So structuroplasty, we have four types: Henke-Mikulai's, Fine, Gipoli, and side-to-side. Okay, let's move a little bit. And as we said, the colon and rectum is not the most commonly involved in Crohn's disease. It's the terminal ileum, and we covered that previously. We said the terminal ileum, ileocolic resection, high rate for controlling the disease. But if we have a colonic or rectal involvement, we have different type of surgery. Of them, we have total proctocolectomy or total abdominal. The rectum is left. Total abdominal colectomy with ileostomy, or total abdominal colectomy with ileorectal anastomosis, or segmental resection. Of course, the total proctocolectomy, lower recurrence when we compare it to segmental resection or total abdominal colectomy. Okay, if we have a problem such as toxic colitis or toxic megacolon, so the surgery is total abdominal colectomy with end ileostomy, irrespective of the rectal involvement. We will see in the next few seconds that we try to avoid surgery in the rectum. Actually, the rectum is not commonly involved in Crohn's disease, but not for that only. Also, surgery in the pelvis is not an easy and associated with many risks. So, toxic megacolon, total abdominal colectomy with end ileostomy, irrespective of the rectal involvement. If the rectum is involved, we usually, as I said, want to avoid surgery on the rectum, so we have different modalities to keep the rectum. For example, we can do total abdominal colectomy with end ileostomy and put a rectal tube, or we can bring the rectum as a how I can say it, we can close it and put it in the left lower quadrant, so that the stump is intraperitoneal at the left lower quadrant, and if leak will happen, it will manifest as wound infection rather than sepsis. Again, if the rectum is affected, we proceed, even the rectum is affected, we proceed to total abdominal colectomy. We do not proceed to total proctocolectomy. We proceed to total abdominal colectomy with end ileostomy. We close the rectal stump. We can put rectal tube or bring the rectal stump near the left upper quadrant, so it is the leak will manifest as wound infection simply, not a pelvic sepsis. If we have a short segment, we can proceed to segmental resection. If we have two separate segments, we proceed to resection of these segments in continuity, not separate segmentectomy. Okay, we mentioned that smoking is a risk associated with the need for other surgery and the need for proctectomy. The more distal the disease, the more likely we have a permanent stoma. The recurrence risk and the risk of permanent stoma is high in perianal involvement, is high when the patient is young, is high in female patients. Okay, we covered most part here. Here just they compared the segmental resection to, we mostly said the most important topics. Ileal pouch anal anastomosis in Crohn's disease looks strange a little bit, because ileal pouch anal anastomosis is not designed for Crohn's disease but for ulcerative colitis, when the patient is desiring to keep the continuity of the bowel. But the idea here appeared when we operated a patient for ulcerative colitis, and post-op we find that they are Crohn's disease. We have misdiagnosed them. So we investigate patient with ileal pouch anal anastomosis. We bring the ileum to the anus with a creation of pouch by the ileum without the stoma, if it is a single step surgery or one stage surgery. So It's not the ideal surgery for a Crohn, it's for ulcerative, but we investigated. Of course, we remember that the Crohn disease is a disease of the terminal ileum, disease of every part in the small bowel. So failure of this pouch is higher than ulcerative colitis. It's about 15% the failure of this pouch. We will see it in detail in the ulcerative colitis management, but we have to remember that ileal pouch anal anastomosis for Crohn disease is higher failure rate, about 15, while the failure rate when we compare it to ulcerative colitis, it's only 5%. Okay, is ileal pouch anal anastomosis contraindicated in okay, again, is ileal pouch anal anastomosis contraindicated? We can say it's sometimes an individualize a selective decision for some patients, especially in those who have no perianal involvement and no small bowel disease. We selectively can proceed to ileal pouch anal anastomosis in Crohn disease. Okay, the pouchitis physiology. This is with regard of how pouch and the change of microbiome in the pouch. Nothing specific to talk about. They said, for example, that pouchitis, actually, we will discuss it in the ulcerative colitis. It's when we bring the ileum to the anus, we do a pouch to reserve the stool. This pouch can present as can be complicated with infection, and it presents mostly like diarrhea, and the pouchitis failure is higher in ulcerative colitis when we compare it to not Crohn disease. Crohn disease is not the classic option for when we do FAP surgery. So the pouchitis failure is high in ulcerative colitis when we compare it to patient with familial adenomatous polyposis surgery. These are the two main diseases that we use as pouch. Other talk is about how the microbiome alter. Immune and microbial change is generally not some genetic study, not that important. Okay, about the iliosigmoid fistula, it's nice to just, most of the iliosigmoid fistula from the ileum to the sigmoid, most of them are asymptomatic. They present like diarrhea as bypass of the continent from the ileum to the sigmoid. Most of the surgery is ileal resection with primary sigmoidal repair, but this is up to 75% of the patient can be treated like this with resection of the ileum, repair of the sigmoid. The 25% are require a resection of the sigmoid. Okay, we actually completed the treatment or covered most of the topics in the treatment of Crohn disease. We now move to surgical treatment of ulcerative colitis. Dear colleagues, we reach our last topic, and it is the surgical management of ulcerative colitis. And if we are talking about the key concept of ulcerative colitis and its surgical management, so the first note is to notice that moderate to severe ulcerative colitis, the management of moderate to severe ulcerative colitis, instead of treating this patient for a long time with a step-up approach and adding combined therapy and switching from one biological agent to another, it's now preferred for early surgical management or early surgical referral. So we do not wait that long while the patient is suffering, and many medications have many side effects. So early surgical management in moderate to severe ulcerative colitis is advised. Of course, also in severe. Okay, here is the standard surgery. The ileal pouch anal anastomosis is designed for ulcerative colitis. So, anal pouch, ileal pouch anal anastomosis is the standard surgery for whom? For those who will undergo surgery and are medically refractory or with cancer, with dysplasia. We will see in the few minutes what are the indication for surgery. Of course, the ileal pouch anal anastomosis. Here it is. Ileal pouch anal anastomosis actually can be done in one-step surgery, in two-step surgery, or in three-step surgery. This depends on many factors. Of them, these are the pre-operative nutritional status, the corticosteroid use, and some intra-op consideration or factor. In some patients, we can proceed only to total proctocolectomy with end ileostomy or continent ileostomy. We will see in a few minutes what does continent ileostomy mean, or we can proceed to ileorectal anastomosis. Yes, the rectum is the most common part affected in ulcerative colitis. It's better to remove it and do ileal pouch anal anastomosis, but in selective patient we can proceed to ileorectal anastomosis. Okay. Actually, about 30% of patients with ulcerative colitis will undergo surgery during their lifetime. 90% of these surgery are elective, and only 10% are emergency. Example of the indication for the elective surgery, those who are, of course, we said that 90% is the percentage for elective surgery. Of these indication are medically refractory colitis, these who do not respond to medication, the complication of the disease, the side effect associated with the medication, the extraintestinal manifestation, growth retardation in children, and dysplasia, either high grade or multifocal dysplasia, or cancer. Okay. The overall risk of developing cancer in ulcerative colitis is about 4%. Okay. The cumulative risk, if you remember, we said in Crohn's disease 369, 3% after 10 years, 6% after 20 years, and 9% after 30 years. It's a little bit high in ulcerative colitis. After 10 years, it's 3%. After 20 years, it is 9%. So we move 3, 9, and after 30 years, it's 18%. Again, 10 years, 20 years, 30 years. 10 years, 3%, the risk of developing cancer. 20 years, 9%, 30 year 18%. Okay, high risk for developing cancer, these are young patients. We are talking here. Okay, young age, those who present with ulcerative colitis early in their life, pancolitis, moderate to severe colitis instead of mild to moderate, family history of CRC or colorectal cancer, and this is the strongest risk factor, and primary sclerosing cholangitis. The surveillance, it's similar to the surveillance we already talked about. It is after 8 years from establishing the diagnosis or at the time of discovering primary sclerosing cholangitis every 1 to 2 years. It's preferred to use the modality on colonoscopy called chromoendoscopy and high definition endoscopy. Also, the biopsy, we already talked about that. We take random biopsy every 10 centimeter, plus, this is random, plus targeted biopsy of any, what does targeted biopsy mean? Any visible, any raised lesion, we take a biopsy. Okay. Also, it's written here, by the way, anyone who wants to read the textbook or the PDF version, I can send it to him or her. Okay, again, in the past, high-grade dysplasia or multifocal low-grade dysplasia, these were an indication for colectomy. Even when I was a resident, these were the textbook that I read at that time. This was an indication, were an indication for colectomy, high-grade dysplasia and multifocal low-grade dysplasia. Currently, this depends on many factors that we already mentioned, such as, is this lesion visible, polypoid, raised? If these are polypoidal lesions, so endoscopic resection with short time for survival is enough. But if these are invisible biopsy found on random biopsy, so with high-grade dysplasia, so we recommend to refer the patient to a center where the gastroenterologist have chromoendoscopy and high-definition colonoscopy, because these modalities are recently used in the GI centers. So it's advisable to send the patient again to do colonoscopy with chromoendoscopy and high definition endoscopy. Okay. Regarding the emergent surgery, you may say that you make a little bit the indication for colectomy not clear, and it's not clear. What we found in surveillance colonoscopy and the indication for colectomy is not clear recently. Why? Because this modality, chromoendoscopy or high definition colonoscopy, are newly used in the worldwide. So we prefer the patient to repeat the traditional or conventional colonoscopy with this modality. to repeat them using chromoendoscopy and high definition colonoscopy. So what is clear till now that if there is a polypoidal lesion, even it's high grade dysplasia, we can just go for endoscopic resection. If it is clear that it is high grade dysplasia on high definition colonoscopy or chromoendoscopy, so we can proceed for colectomy. I hope that I could deliver the information well. Okay, regarding the emergent, these are that we talked about the elective indication for surgery, the emergent indication for surgery, and of these are the acute severe ulcerative colitis, and about 25% of patients with ulcerative colitis will present as acute severe ulcerative colitis. Other indication is sepsis, toxic megacolon. What does toxic megacolon? It's acute severe ulcerative colitis plus radiological dilatation. Perforation is an emergence indication, and severe bleeding. Okay. Also here they define what does acute severe ulcerative colitis mean. Where is it? Where is it? I think yes, it's here. And we already talked about that. It is according to the True Love and Wit criteria. It is bloody stool more than 6 time per day, and at least one systematic toxicity such as heart rate, temperature, hemoglobin low, erythrocyte. Okay. They talk here a little bit about the treatment of acute severe ulcerative colitis, and we already covered that. We said that we start with medical management with IV corticosteroid, IV fluid, electrolyte replacement, thromboprophylaxis, pain management. We avoid steroid and opioid for in this patient. We should screen for C. difficile and cytomegalovirus. We can do flexible sigmoidoscopy for biopsy to rule out this infection. We can use infliximab biological as a medical treatment for induction of remission in this patient. We can use calcineurin inhibitors such as cyclosporine. If this failed, we can proceed to colectomy in a form of total abdominal colectomy and end ileostomy. We do not touch the rectum in emergent surgery. Okay. Again, this is the emergent surgery we proceed for is total abdominal colectomy and end ileostomy. Rectum, even disease, left as Hartmann stump. If we worry about the rectum and you don't want to leave it as a rectal stump, you can put a rectal tube, you can bring it as a mucus fistula, but surgery in emergent setting in the rectum, it's associated with many complications, pelvic sepsis, fertility in females. So emergency, avoid pelvic dissection. You want to do ileal pouch anal anastomosis, it's okay, but a little bit later. Regarding the pre-op planning, if you are going for elective surgery, so it's important to consult or to ask for help from the interostomal therapist or interostomal nurse. They do marking for the site of the stoma. They counsel the patient regarding the stoma. So this is important. Also, if you are going to operate patient and for ulcerative colitis, you have to check the small bowel for involvement. Also, as much as you can please do steroid tapering as tolerated. And at this time, the surgeon should take the lead of preoperative steroid dosing. We said that tapering and stress dose is a little bit cloudy and not clear. We do not push severely to give stress dose steroid and tapering. If it is not tolerated, you can taper it after surgery. Nutritional support, before surgery, preoperative nutritional support, especially in those who have weight loss or hypoalbuminemia. Okay, oral antibiotic, one of the ERAS, one of the enhanced recovery after surgery, and mechanical bowel prep is advised. Regarding the ileal pouch anal anastomosis, it was discovered in 1978. Okay, it can be done on one stage. One stage means you do the ileal pouch. Actually, this is the ileal pouch. If you don't, this is the ileal pouch. Okay, and you do not do without ileostomy. You do not do end ileostomy. So it's a one-step surgery. Actually, you connect the ileum to the rectum. This is ileal pouch anal anastomosis as a one-step surgery. Or you can do it in a two-step, and simply two-step you bring a diverting ileostomy, such as here it is, diverting ileostomy. You give time for the pouch to heal, to mature enough. This is, and the diverting ileostomy, and you connect it after 2 to 3 months. You close the diverting ileostomy, or you can perform it in a 3-stage. A 3-stage, it's simply the first stage you can see here. They proceed for colectomy. They proceed for total abdominal proctocolectomy and bring a terminal ileum as a stoma. The second stage, they create the pouch. They create the pouch, but they didn't connect it to the anus nor or the remnant part of the rectum, and they bring a loop ileostomy. Okay? And the third part of the surgery, they connect the pouch to the remaining part of the rectum, and they close the ileostomy. This is the 3-stage ileal pouch anal anastomosis. Okay, this is mainly many factors play a role, but this is mainly a surgeon preference. Sometime we proceed for 3 stages ileal pouch anal anastomosis in cases of urgency, if it's urgent. Or if we have a preoperative malnutrition, if the patient on high dose of steroid, if the patient is obese, and obesity play many factors why obesity is an indication for a 3-stage ileal pouch anal anastomosis. For example, the visceral fat, the fat around the bowel, can limit the ileum to reach the rectum. This is one of the causes. Other causes that obesity as a risk for leak. So we proceed for 3 stages. And actually we advise this patient to lose weight so that the body mass index is below the 30. Female who are requiring or desiring pregnancy also are advised for 3-stage ileal pouch anal anastomosis, because any surgery in the pelvis will limit or decrease the fertility in female. Also, if the diagnosis is uncertain, we are not sure is it Crohn or ulcerative. Also, another indication is cancer. Okay. Can we proceed for the laparoscopic approach or open approach? It's surgeon preference again, but the laparoscopic approach found to be of a less adhesion and more better regarding the fertility, especially in female. Regarding the operative technique, I think it's not it's not extremely important for us as a general surgeon. They talk about the steps of surgery from A to Z. It's not necessary to remember this. What I remember from while I was preparing for my surgical board, that in ileal pouch anal anastomosis, we do not remove all the rectum. Some of the rectum is left, so we do mucosectomy. We remove the mucosa of the rectum as a risk of cancer exists, and there is a picture here, I think, for mucosectomy. These are the steps for surgery. Excellent. Okay, I think here is the how the pouch is done. The pouch, by the way, first was designed as S pouch. I think I have, this is mucosectomy. Actually, they removed the mucosa of the remnant rectum so that the risk of cancer is diminished a little bit. Transanal mucosectomy. Okay, where is we will talk about the mucosectomy. We talked about what else? These are the optimal pouch design. The first pouch was designed as S shape. This is S shape. I think they mean that this is S. Okay, S shape. We now used, while in adventing the staplers, we use J pouch. If we compare S versus J pouch, actually these are the same outcome. J pouch is a little bit associated with higher stool frequency. Okay. Okay, this is regarding of the optimal pouch design. We said no one is superior to the other. It's a surgeon preference. This how J pouch looks like. I think they mean J, that's like this. Okay, or small letter J. Okay. This is J, this is S. What's we have? W also. Pouch. And what's this? This is lateral isoperistatic reservoir. Okay. Type of anastomosis. Should we proceed to hand-sewn or stapled? Okay, and there is no superiority of hand-sewn over stapled or the stapled over hand-sewn, and this is what's written here. It is no superiority. Actually, the stapled anastomosis found to be associated with decreased the short term morbidity, but the long-term morbidity is the same. It's surgeon preference. Okay. Regarding the transanal pouch. Actually, what is transanal pouch? It's creating the J pouch, the W pouch, the S pouch transanally. And this is important in the laparoscopic approach. As in laparoscopic approach, it's difficult to create the pouch. So transanally, we can create the J pouch, and that's all the information that we have to know. If it's open surgery, so you can create the J pouch intraperitoneally or transabdominally. Okay. We said that in some or in selected patient we can proceed for iliorectal anastomosis, and this means that we leave the rectum, we avoid surgery in the pelvis, and this is associated with lower technical demand. It's easier. It eliminates the pelvic dissection. We do not need to do pelvic dissection. It's associated with lower pelvis sepsis, and it's associated with better sexual and urinary dysfunction and better infertility. It's not the standard surgery. An example for patient who can proceed for ileorectal anastomosis is those, we said, those who are uncertain about the diagnosis. We are not sure that it's ulcerative colitis, or female who require pregnancy. We avoid pelvic dissection. Of course, the cancer risk recurrence in ileorectal anastomosis is higher if we compare it to ileal pouch anal anastomosis. It's about 3% in ileorectal anastomosis, while ileal pouch anal anastomosis it's 0.5. Okay. I don't know why they mentioned here continent ileostomy. Actually, these patients who cannot proceed for ileal pouch anal anastomosis or will have end ileostomy but brochy ileostomy failed. Actually, ileostomy is associated with high morbidity and high output, so they create a reservoir or a pouch of the small bowel before the stoma opening, so the stool can accumulate before it comes out. And these are indicated when, as we said, when brochyeliostomy or nippling of the ileostomy failed. For those who have, for example, significant or severe perianal fistulas or disease, poor anal sphincter function, so the ileal pouch anal anastomosis will not work well. Occupation that cannot be or occupation that preclude frequent visit to toilet, for example, pilots. So we do continent ileostomy. I hope you are understanding the concept of continent ileostomy. It's creating a pouch of a small bowel so that the stool can accumulate before we intentionally evacuate this stoma. Of course, continent ileostomy is contraindicated if we are suspecting Crohn's disease, because Crohn's disease is associated with high failure of the continent, and these who are obese, who have age above 40, these are relative indication. Absolute contraindication is Crohn's disease, and relative contraindication is obesity and age above the 40. Actually, we finished the most topic that we have to cover in surgical management of ulcerative colitis. I hope I delivered as much of the information I have in an easy and a simple way. I know it was long, a little bit hard lecture. If you reach this point, so that you are a good fighter, you are a good soldier. Thank you, and I hope we will meet in the next lecture. Bye bye.